Hello, everyone. Welcome back to Neurospicy Nursing. We are going to be going over genetics and genomics in pediatric nursing. We're going to figure out why these conditions happen, how we support the tiny humans and their families through learning that they have these disorders. All right, so just kind of a quick intro into the difference of genetics and genomics. Genetics is looking at one gene at a time. We're thinking mutations, deletions, duplications. They're little tiny edits that can change the whole story, right? Changes everything when we have these small little edits in our genes. We use genetics for diagnosis and for precise medicines. I'll give you a perfect example in some cancer research. There are specific chemotherapies right now that are in drug trials that are specific for certain mutations, right? So they need to have a specific mutation present in order to get on this chemotherapy. So that's one example. And then genomics is that zoomed out picture. It's looking at all of the genes working together, and it's used especially in complex diseases, and this is where research and the personalized care end up living. So, just to kind of break it down and think of it a little bit easier, genetics is more like a chapter, and genomics is the whole book. All right, so chromosomal abnormalities. These are the big picture changes. These are irregularities in the number or the structure of the chromosomes. It can either affect the autosomes or the sex chromosomes, or sometimes even both. And it can pretty much happen at any point. It could be during cell division, pre-implantation, during pregnancy, or after birth. But what happens is, since the chromosomes are misbehaving, it can make pediatric care a little bit more interesting or difficult, depending on the type. All right, so there are numeric abnormalities. This is all about the count, right? So normally we have 46 chromosomes. That's what we're talking about, like sperm or an egg. Those have 23, but to make a baby, they add together and make 46. Um, so 46 chromosomes is how much we normally have. If the number is off, we call it aneuploidy, which just stands for abnormal number. Monosomy means one is missing, and trisomy is an extra one. I like to think of it as monosomy is you're missing a friend, and trisomy is you brought a plus one. All right, so structural abnormalities. These are all about the shape and or the arrangement of the chromosomes specifically. Deletion, you're missing a piece. Duplication, there's an extra copy. Translocation, a piece has moved somewhere where it's not supposed to be. Inversions is the DNA has now flipped end to end. And then ring chromosomes is it kind of loops into a circle. Chromosomes are interesting. They could bend, they could break, flip, flop, fuse, do everything. They're just kind of drama queens. They don't want to follow the rules. They do what they want, and they do what they will. All right, so trisomy 21. This is Down syndrome. It's one of the most well-known chromosomal conditions. The etiology of it is that there is an extra chromosome of chromosome 21, and we're gonna diagnose it using prenatal screening and karyotype confirmation. One of the most notable risk factors is going to be advanced maternal age, and then there's obviously clinical features that are distinct to trisomy 21, which are those distinct facial features, hypotonia, congenital heart defects, GI abnormalities. There's hematologic risks as well as developmental delays. All right, getting into monogenetic disorders, these are Marfan and neurofibromatosis. Say that 5 times fast. Neurofibromatosis. Marfan is a connective tissue disorder. They have tall stature, long limbs, aortic root dilation, as well as they are autosomal dominant. Neurofibromatosis has a distinct feature of what we call cafe au lait spots. They will also have tumors that are on their actual nerves, and it's autosomal dominant. So you might be like, what does autosomal dominant mean? So that just means that only one parent needs to have the gene for the child to end up with the disorder. They don't both need it because it's dominant. Only one of them needs it. Okay, moving into autosomal recessive, we need two copies of a gene, one from each parent, to end up with these disorders. The first one is Tay-Sachs, which is neurodegenerative. There is no cure, and it's more common within certain subsections, certain populations. And then there's congenital adrenal hyperplasia. They will have an adrenal hormone imbalance. They also have the possibility of having ambiguous genitalia, and they will need lifelong steroid management. So we've talked about it a little bit in the past, but just as a reminder, when we're on lifelong steroid management, it's going to affect our immune system. We now are at risk for Cushing's. We're now at risk for osteoporosis and decreased immunity. So these are other things that we're going to have to make sure that we're paying attention to, on top of the fact that they have already a recessive disorder just because of the medication that they're taking. All right, so X-linked and imprinting disorders. This is all about the inheritance patterns. And what I mean by that is, especially when it comes to imprinting, that means that which parent the gene came from is actually going to matter. It's important to know which parent that gene came from. So, looking at the first one, which is Turner syndrome, they have a short stature, a webbed neck, they can end up with infertility, and it's going to be something that only affects females because males have an X and a Y chromosome, females have two X chromosomes. So what ends up happening is just one of those X chromosomes isn't there. That's the biggest difference. Okay, so Prader-Willi syndrome, they will have hypotonia in infancy, which later will end up being caught, well, later in life ends up causing hyperphagia. They also have a risk of obesity and behavioral challenges. And then there's Angelman syndrome, and unfortunately, they are at risk for seizures, ataxia, and a happy effect. A happy effect isn't a bad thing, but seizures and ataxia are. Slide 10, the nursing role. This is the last slide that we're gonna go over. Um, it's really important as nurses, to recognize our role in genetics and genomics, especially when it comes to translating this crazy medical jargon into an understandable language for our parents. Providing clear and simple education is a huge, huge part of the nursing role. Also, we're going to support the family coping. It can be very, very stressful to hear that your child has a disorder like this because unfortunately some of them can shorten lifespans sometimes depending on the genetic disorder. And that could be horrifying to hear. So supporting them is important. Coordinating any genetic testing is also going to be important. Monitoring for developmental milestones is important. Advocating for early intervention, as well as helping to collaborate with some specialists. Okay, that's slide 10. And then this is my resource pages. A little bit different than normal. I just wanted to make sure I got everything really, really in depth and a little bit like, yes, at a basis level, but a little bit more in depth just so that you guys had the information. So feel free to check these out. And that's all. All right, guys. Thank you so much and have a great one. Bye.